In the cardiac care unit, some ECG patterns represent immediate threats to life, often preceding sudden cardiac arrest or profound hemodynamic collapse. While some are obvious, others are subtle, wolf in sheep's clothing patterns. Here are 5 potentially lethal ECG patterns every clinician must recognize instantly. Wallens syndrome indicates a critical high-grade stenosis of the proximal left anterior descending coronary artery. Patients are often pain-free when the ECG is taken, but they are at imminent risk of a massive anterior myocardial infarction, the so-called widowmaker. Occurs in leads V2 to V3. Type A is biphasic T waves, initial positivity followed by terminal negativity. Type B, deeply and symmetrically inverted T waves. Do not put these patients on a treadmill for a stress test. It can provoke a fatal myocardial infarction. They need the cath lab. D. Winters syndrome, considered an ST elevation myocardial infarction or STEMI equivalent. This pattern represents acute proximal LAD occlusion but lacks the classical ST segment elevation. Upsloping ST segment depression more than 1 mm at the J point in leads V1 to V6, followed by tall, prominent symmetrical T waves, often accompanied by 0.5 to 1 mm ST elevation in lead AVR. That's always a reciprocal pattern. This is an active, evolving myocardial infarction that requires primary PCI immediately. Brugada syndrome is a sodium channelopathy that leads to ventricular fibrillation and sudden cardiac death, often in young, otherwise healthy patients. The type 1 or pathognomonic pattern is code ST segment elevation more than 2 mm in more than one right precordial lead V1, V2, followed by a negative T wave. The pattern can be unmasked by fever, certain medications or electrolyte imbalances. If you see this in a patient with a history of syncope, it is a high-risk emergency. Severe hyperkalemia, typically potassium levels above 7 milliequivalents per liter, can lead to sine wave patterns and asystole within minutes. It is lethal because it progresses rapidly. Peak T waves, narrow-based tended T waves across all leads. P wave flattening leading to the disappearance of P waves. QRS widening. The QRS begins to merge with the T wave. Sine wave pattern, the ultimate pre-terminal rhythm in which QRS merges with the T wave with no ST segment in between. Management is immediate intravenous calcium gluconate or chloride to stabilize the cardiac membrane. DOSA at the point is a specific form of polymorphic ventricular tachycardia occurring in the context of a prolonged QT interval. It is lethal because it frequently degenerates into ventricular fibrillation. The QRS complexes appear to twist around the isoelectric line, constantly changing in amplitude and axis. Usually initiated by a premature ventricular complex falling on the prolonged T wave of the preceding beat or the R on T phenomenon. Unlike standard ventricular tachycardia, primary treatment here is intravenous magnesium sulfate, even if serum magnesium levels are normal. You must also identify and stop any QT prolonging drugs.